Hello and welcome to tonight's Rural Doctors broadcast. I'm Jerry Gannon. Thanks for your company. Our program tonight looks at trauma and emergency medicine and features a discussion between our own Dr. Olga Ward and Dr. Gary Wilkes, Medical Director of St. John Ambulance. They'll cover topics including new EMST ATLS recommendations, securing an airway, head injuries and managing large haemorrhages. Throughout the broadcast, we'll also hear from clinical psychologist Dr. Daryl Managlio about psychiatric emergencies, including recognising and managing suicidal patients and dealing with aggressive or manipulative patients. Dr. Managlio has worked at Greylands and within the prison system and has some good advice about maintaining your personal safety and your professional distance. But for now, here's Olga with quite a regular guest on the programme, Dr. Gary Wilkes.
Gary, welcome to the program.
Thanks for having me, Olga.
Gary, I understand that there's been some developments with the ATLS and EMST courses and that there are now some changes being taught.
Yes, indeed. Well, as we all know, the ATLS manual gets updated every couple of years or so, and the same manual's taught on a worldwide basis. The 8th edition has just come out, was released in the United States in late 2008, and it's now started in Australia. And this one's a fairly major turnover compared to the previous ones. Previously it's just got a minor wording and stuff changes, but this one's got a whole new look and feel to it.
Okay, so are there any major changes in trauma management for 2009?
I don't think there's major changes per se, but more a refinement of what we already do. One of the things from this manual in particular is that it's taken a lot of the Australian bits and pieces into it. So those doing courses will see, for example, things like the laryngeal mask and the bougie, which we're very comfortable with in Australia, have now been incorporated into standard airway management. But there's been a whole number of changes all the way. The ABC and even the APC itself has actually changed for some situations.
Yeah?
Well, for the in military in particular, I guess the United States has had a lot of experience in war, and so have we in recent times. And there's a recognition now that the basic principle in ATLS is deal with the greatest threat to life first is there. So in a battlefield situation, or whether you're at the scene of an actual accident, the C comes before A. We know with an airway obstruction, then you can die within about 4 minutes, but you don't die earlier than that. You can sustain a period without ventilation and with an obstructed airway. But if you have a massive hemorrhage, such as having both your legs blown off in a battlefield, or shark attacks that we see, because arteries don't spasm when they're actually in contact with liquid, then you can bleed to death in 30 seconds. So in those people, compression of the bleeding point takes precedence over airway if you're actually at the scene of the accident. So now it's described as C, with the C in brackets, ABC, if you're actually at the scene of it taking place.
When we were talking about the new changes with EMST, you said that on the website there was some update multiple choice questions that doctors could do.
Yes, well, ATLS has now gone live and online, and welcome to the new millennium. There's a website you can go on which takes you through the changes. It's got a little educational part to it. It takes about 20-30 minutes maybe to read through the summary sections of the changes that are in there. And then there's a multi-choice question. I can't remember actually, I think it's about 24 questions or so at the end of that. Now, you can have a choice of doing that as a CME exercise if you wish to do it other than just for personal experience, and at the end of it, it will send you a CME certificate, or sorry, you have to print out a CME certificate for that. And if you're an instructor, for example, it's now compulsory that you do that every 4 years to recertify. So you notify where you're from, and the website organisers will actually send that to the organiser. So for us, it would be the College of Surgeons who receives that.
And if a doctor is, say, registered to do the EMST course or the ATLS course, yes, is that one of the pre-requirements?
It's highly recommended that you go and do that, simply because on the EMST course, those who've done it will know when you do the course, you do a multi-choice test prior to the course. Now, the one prior to the course you have with your book, so you can sit down and do it, and then at the end of the course you get to do another one without the book. Now, hopefully you've now learnt it, and you must reach a certain level to get through. So it's a good little aid memoir to get through. They've selected the questions really nicely. They take out on the web ones, the relevant changes. And it's for those who want to go and do it, it's actually impossible not to get 100%. If you do select the wrong answer, then it'll tell you what the correct answer is and why. So it's a kind of learning exercise as you go along. It's very, very non-threatening.
Well, despite the shark attacks and the legs blown off, could we start by talking about airways? That's something that's quite difficult for rural GPs, particularly in that we have to intubate unstable patients if they're going to be transported with the RFDS. So do you have any hot tips for difficult airways?
I'm not sure I've got that many hot tips other than be calm and do what you normally do. We all know that the person who is right to intubate a trauma patient is someone who is experienced in intubation. And I personally would have a lot more faith in an experienced GP who does regular anaesthetic lists and intubations. I think they would actually have better skills than me doing intubations, because although I get to deal with the difficult ones, I don't do them anywhere near as frequently. So stick with what you're comfortable with and do it in the way that you are comfortable. So if you normally use graded sedation, use graded sedation. You don't want to overshoot it though. Things like midazolam in somebody who has a poor circulation can take up to 15 minutes to work. Even intravenously can take 15 minutes to work, and then suddenly your blood pressure drops down the track. So if you have a patient who's compromised cardiovascular-wise, then the idea is to go very gentle and use drugs that have less effect on blood pressure. Fentanyl's probably the best of the lot, and it's very, very cardiovascular clean.
I think most rural GPs would use fentanyl and a small amount of midazolam, because I think that's mostly what's unimpressed in the resus trolleys.
I always hark back to during my anaesthetic training as a junior, when we did our cardiothoracic and our neurosurgical list, our induction agent was just fentanyl.
Yeah.
No midazolam at all, and that's very, very cardiovascular clean.
Now we've seen a real trend to using a laryngeal mask for anaesthetics, and I noticed recently in the trauma course that they're also popping up in emergency medicine courses. What's the place of using a laryngeal mask in a resus?
I think a laryngeal mask has a lot to recommend it in trauma. We all know a definitive airway is a cuff blown up in the trachea, which can either go in orally or nasally. We don't tend to use nasal in Australia. In fact, even in the United States, they don't tend to use it. It's just there, I think, mostly for historical reasons. A laryngeal mask, although, is still a decent airway if you're having trouble maintaining the airway. I always recommend to people that if you need to intubate somebody, then it may just be that you haven't got the patient positioned correctly. So if you have a conscious patient who doesn't need intubation for other reasons, then the easiest way to actually clear the airway in head and facial injury is to actually have them on their side. And having them on their side is a reasonable thing to do, even with the presence or concern about cervical spine injury, provided you maintain that neutral alignment. You can do that with a collar, you can do that with appropriate sized pillows or towels along the head. And in fact, when somebody is on their side with facial injuries and with blood or anything in the way, the stuff drains out quite nicely. Yeah. Even for an unconscious patient, it actually does quite nicely. So if you don't feel as though you have the skill to intubate and you don't want to just have a go, because trauma and major trauma is not the time to have a go, you want to do what is safe and sensible, well, I recommend putting them on their side.
Yeah. You can actually roll them on their side on a spinal board anyway.
Oh, absolutely. Well, in fact, you don't even need that, because the body is fairly rigid, it's fairly controlled, and provided you have them positioned on their side and neutrally aligned, it's actually quite easy to do. Head injuries have no trouble breathing. In fact, if anything, it stimulates breathing. But lying flat on your back with facial injuries, with blood, alcohol and other stuff there, that's actually a major threat to an airway. So have them on their side. If you do need to intubate them, you intubate them in the normal way on their back and with assistants who know what they're doing. Yeah. So the laryngeal mask is actually quite useful. It's not a definitive airway, so you can still get stuff leaking around it. And what they're doing in America now, the ATLS course, is recognising that the LMA is a useful fallback position in that difficult airway situation where you want to intubate but you can't.
Just really trying to get some oxygenation and...
Absolutely. And the other thing, of course, is a surgical airway. Now, surgical airways terrify people. They're really scary, they're horrible, and they seem like a really difficult thing to do. We take a great deal of time on the EMST courses, ATLS courses, in teaching people how to do a surgical airway. It's actually a very easy procedure. You can do it in about 15 seconds. It takes no special equipment, and the hardest bit is convincing yourself to go ahead and do it. I remember the very first one that I did, and I was terrified going and doing it, but once I did it, I was more comfortable with it, and now I do them on a reasonably regular basis because I know they're easy to do, they do give you a definitive airway, and it's actually it's a great procedure.
Quite time limited, aren't they, in the amount of time that you can use a surgical airway, unless you've got a proper mini track kit or something.
No, the material I use for a surgical airway consists of a scalpel, a pair of forceps, and an endotracheal tube. That's it. I don't use any fancy equipment because I think people mess around too long playing with the pack and doing stuff, whereas they should just get in there and fix the airway. A needle in the airway will buy you a little bit of time, a 14 gauge needle in an airway. People have very elaborate setups for ventilating through a needle. I tell people to use what is available in their normal bay. The standard endotracheal tube in trauma, the one size that fits all is a size 7. The standard cannula in trauma that you want to fit is a 14, and you want to get a 7 endotracheal into a 14 cannula. So if you just do the math, that's a 2. So if you take the connector out of a size 7 endotracheal tube, that fits very snugly into the barrel of a 2mm syringe, and then that syringe can hook onto the needle. So you can in fact use your ordinary bag to ventilate through that, and that takes you, 5 seconds to set up, and everyone has a size 7 endotracheal tube, everyone has a size 2 syringe, no cutting, nothing involved.
Gary, sometimes you're not sure whether or not your ventilation is adequate, and sometimes you're not sure if your ventilation of the patient is a little bit over-enthusiastic. How do you know?
The only real way to know is to measure carbon dioxide levels, either by blood gas analysis or by a detector, a monitor detector as we use in anaesthesia that gives you an actual number, or you can use those colour litmus paper ones that change, but they're a very broad sort of range. If somebody is being ventilated, typically we are very over-enthusiastic. It's a high adrenaline situation, we squeeze away. And for example, in cardiac arrest, the average amount we ventilate in cardiac arrest is more than 50 ventilations a minute. We really go over the top. And that's actually bad for you because the low CO2 causes cerebral vasoconstriction, and in the setting of head injury in particular, you're actually reducing cerebral perfusion. If you don't have those material available, and you're ventilating by hand, you give the patient a breath every time you take one. And it's one hand on the bag squeeze, not squeezing the entire bag to completion. Because you and I are sitting here breathing normally, we only breathe in about 500 mils of breath. So it's about 7 mils a kilo or so.
Do you have any other tips on managing cervical spine injury whilst trying to manage an airway?
We always worry about the cervical spine. I take a lot of solace in the fact that although we worry about cervical spine, the actual incidence of cervical spine injury is quite low. And we also know that no one, certainly in Western Australia, when I've gone through the records, has ever deteriorated after they're first discovered. Most of the injuries are apparent right from the very outset, and we don't know of anybody who's had an injury subsequent to being rescued. So whatever we're doing looking after cervical spines is quite good. If you think about the mechanisms that are necessary to snap the spine in the first place, then basically anything you do other than grab them by the head and swing them round isn't going to do any harm. Maintaining that neutral alignment, gently rolling them if you have to, because airway does take priority over cervical spine. And there's been a lot of downplay about not moving or touching the patient because of the fear of cervical spine injury. The key is airway and ventilation. So if you have to move them on the side, you move them on their side, but just make sure you keep them aligned and comfortable.
That's encouraging. Gary, there's been a lot of topical interest in head injury since Liam Neeson's wife died of her head injury whilst skiing. How much benefit do you see in helmets for cyclists and skiers?
I'm not sure about skiers. There's not a field that I've got much experience in, but cyclists, there's absolutely no doubt. The incidence of severe head injury in cyclists has just dropped off dramatically, especially for kids, and more recently in adults. The number of people we're seeing with who get admitted to hospital now with cycling injuries has steadily increased over the last 30 years or so. But I think that's a sign of more people are actually getting out cycling now than previously. There's no doubt they dramatically decrease both the incidence of injury that requires treatment, and when people do arrive, the severity of those injuries.
Treatment of head injury is often quite confusing, and we've seen recommendations for mannitol and then for not mannitol, at one stage possibly for steroids and then not for steroids, and then different levels of blood pressure to maintain cerebral perfusion. How do we know what to do? It's
terrible, isn't it? It gets very confusing because everyone likes to throw in their little bit and remember what we got taught when we were medical students and juniors. In fact, the evidence behind this and the rationale behind this is actually very simple. There is no evidence that steroids do any good in head injury. In fact, there's good evidence they worsen it, so it's definitely not recommended. It has been trialled, but not found to be beneficial, so I wouldn't even consider steroids in head injury. Mannitol's a little bit of a trickier one. What mannitol does is it dehydrates you. It's an osmotic diuretic, so it draws fluid out. So if you have someone who's coning right in front of you, mannitol is useful. It's definitely not useful as a prophylactic medication, especially if it's going to be many hours until you get to definitive care. And for vast majority of rural Western Australia, that's many hours until definitive care, in which case mannitol has virtually no role at all. It may be useful to buy you a bit of time, and by that I mean an hour or two, prior to decompressive surgery if somebody's coning, but it's really not there. So, but the best way around this is to just ring up. You have a patient who's head injured, you ring up the neurosurgical service. They supply a fantastic service. You can speak to people about what they want, and if they recommend the treatment, go ahead and do it. But with mannitol, be wary. The urine output's going to increase. They're going to need more fluid, and the way they're going to go.
Does it also screw up their electrolytes? Will we have to worry about that?
It can, because with the diuresis you lose potassium as well, the same as if you're using ordinary diuretics. It'll go down there. Natasha, who died, she's a classic head injury case. She had an extradural. I'm not sure if you remember much of the detail on the story, or many people do, but she was skiing, bashed her head. I'm not sure whether she was knocked out or not, but she got up, continued to ski, went back to her cabin, became unconscious and died. It's the classic talk and die scenario of an extradural, a bash to the side of the skull, hematoma expanding with no obvious signs externally, and then a sudden deterioration down the track. And the only thing that could have saved her at that point was to have that drilled.
So I guess that leads us on to concussion, which is the most common thing that rural GPs see. Many Natasha injuries coming off the football field and occasionally off the netball field. Are there any hard and fast rules about how often to observe, how long to observe, whether to observe?
Concussion, I wish I knew the answer to this. We all know how to handle the really severely head injured patients. In fact, they're very easy to look after in terms of what do you do, because it's obvious. And in fact, when you look at different institutions, the outcome from head injuries is identical, but when you of the major head injuries. But when you look at the minor head injuries, and someone did a survey on this in the United States, the mortality from minor head injury varies by between 20 and 40 times between institutions, solely on the basis of how they manage their minor head injuries, because they are by far more common. We know that. I mean, how many times a day do you see someone who's got a concussion? Every day on the football field, and yet only a very small minority of them have that extradural or some other major injury in there. How do you pick them? No one's got the answer to that at the moment. What we can do is pick the sort of time interval that goes on. Most extradurals who deteriorate will do so in about the 2 to 4 hour time bracket. Some go on for much longer than that, but generally that's days for it. So that the crucial time is that first 2 to 4 hours to watch people. If we're looking at it from the hospital perspective, then the absolute minimum I keep people for is 4 hours. If you're fortunate enough to be somewhere where you have a CAT scan, then anybody who I see who has an amnestic period, I don't really care if they can tell you they were knocked out or not. I really don't know how people know they were knocked out. They only know they can't remember. Then I scan a lot of them. And the incidence of surgically treatable lesions in that group with a significant amnestic period is only about 1 in 300. It's pretty low. But 1 in 300 who can otherwise be alive and well versus ending up like Natasha did. So I tend to scan them. If you don't have the ability to scan them, then you need to keep them for long enough to be sure that they're not deteriorating. Minimum 4 hours.
Now, when you've got the visiting footy players from a different town and they want to go back on the bus, apart from convincing them not to go back on the bus via the pub, is that all right if they're under observation by their coach or their mates?
I try very hard to have simple ways of, first of all, stop them going back on the field.
Yeah.
And that's very difficult because, especially if you're in finals time and they're a good player, everyone wants them back on the field. So you really need to convince the coach and the other players that they're going to be a liability on the field. And you do that by just testing their brain function. So have them on the side of the field and ask them simple questions. Don't ask them questions they can learn the answer to ahead of time. Ask them who they were marking, who scored last, what the score was when they came off the field. You can test their longer term memory as to who they played last week and who won and so on. You can get them to do simple arithmetic. And if you really want to convince a coach whether a brain has been scrambled good enough to go back on the field, get them to stand with their feet together, arms by their side, and close their eyes. Because one of the first things to go with a decent concussion is balance. And if you see them fall over, well, stand there so they can't fall over, but demonstrate that their balance is no good, then you'll be able to convince the coach, you'll be able to convince them, and convince yourself that they're not stable to go back on the field. Then the question comes as to how long do you watch them for? No one really has the answer to that. Those who are going to go off in terms of extradurals, which are rare, will go off in about 2 to 4 hours. If they're okay from that period, then from the major medical danger, they're fine. But the real question is, how soon can they play football again? How soon can they go back to work and do all the rest? What we do know now is that the whole concussive injury is far more serious than we realise. If you scramble somebody's brain, they don't think properly, and that can last months. Certainly they shouldn't be playing contact sport for a minimum of 2 weeks, probably 3 weeks, because if they get a second injury, then they then treble their recovery time from that, and you run the risk of permanent brain injury. But you need a way of testing whether or not they've recovered so they can go back to work, and only those who know them well can do that, and that's getting them back to their GP, getting reviewed and seeing how they go. It can be a very long course.
And we'll return to that discussion later. As well as physical injuries, there are a number of psychiatric conditions that can pose an immediate threat to life or well-being. Olga Ward caught up with clinical psychologist Dr. Daryl Managlio to talk about some of these circumstances and to get his advice on how to manage them.
Daryl, how would we identify a patient who's a really dinkum suicide risk?
There is a number of things I think you have to look out for. First of all, whether the person's depressed, and that requires an assessment of obviously sort of the usual questions for depression. Whether the depression is chronic and ongoing, or whether it's something that's reactive to current circumstances. If it's reactive to current circumstances, such as a loss of, say, a loved one or whatever, then usually with support the suicide risk will quickly pass. Have there been past attempts? The literature is quite clear that sort of if there has been past attempts, the risk is higher. So certainly I would be asking about whether the person has attempted.
And you would count in that even the young'uns that take a sublethal overdose frequently.
Yeah. Teenagers are particularly a difficult group because they are so reactive and they're so impulsive and unpredictable, particularly in the age bracket from 14 to about 16. So if I get a teenager telling me that they're thinking about suicide, I take that very, very seriously, because I know that they can be fine 1 minute, and happy, and next minute something can go wrong, and they're into their suicidal kind of mode. I also usually want to know what supports the person has. Obviously, the more isolated a person is, the more at risk they are. And the supports that they do have, whether they care about those supports, and the impact that their death will have on those supports. And if they don't care about sort of the impact that the death have, or they'll say things like, "Oh, it's okay, they'll get by, they'll be better off without me," then again that raises for me the level of risk.
I often see people who say, "Oh, I wouldn't do that to my children."
That's a protective factor. So I would be still worried, but sort of not so worried, because I can then follow that up a little bit later with reasons why they would not want to do that, would harm themselves.
So do you have any real key triggering questions that help you work out whether or not a patient's likely to be at very high risk or not?
I'd asked how far their thoughts had gone, how the details of their plans. I'd be concerned whether they've got the means to be able to do it. I would imagine in the country, firearms would be high on the risk, high on the list for that. So I'd be asking their access to firearms, poisons in the country, and the main one is what I said before: is whether they care about the pain and the hurt that they'll leave behind to people who support them or who are their loved ones.
So once you think that a patient really is a suicide risk, how important is it for the doctor to actually seek some team support to help with the patient management, or is this something that one person can actually just provide the support for the patient?
I think there's two things. First of all, there's the immediate prevention, and the most important thing is that if it's determined that the patient is at serious risk of suicide and immediate risk, then you don't leave that patient alone. To manage that patient after that point requires a team approach, and if there is a family in the background that's supportive, I have no hesitation involving the family and informing the family of the risks that are involved. And then beyond that, I would move as quickly as possible, if need be, to get the patient into hospital, be it a general hospital or a psychiatric hospital, depending on any other problems the patient may have.
And in a little country hospital where you may just have an inexperienced patient care assistant as the only person who can watch, is that still a reasonable alternative?
It may be a temporary solution. If it's a reactive style of suicide, in other words, something that's temporary, it might be just enough to get the person over the hump. If it's something that's associated with a more serious mental illness, then probably not. And it's very much only a temporary answer.
So that's when we start to look at transferring the patient to a larger centre or somewhere with a psychiatric unit?
Absolutely.
What kind of other help is available to country doctors?
That's a difficult question for me to answer because I haven't worked in the country. So in my experience with country towns, there's usually a network within the town that supports people. So if there is a mental health patient in town, usually everybody knows, and usually there are nursing staff, volunteer staff, neighbours, etc., who are willing to take care of that patient.
I've certainly found the country mental health team helpful when they can be accessed.
When they can be accessed, yeah.
They're often in an adjacent town or a couple of 100 kilometres away, but at least they're on the phone.
Yeah, I think with those sort of situations, you still may need to move quickly and even bypass the mental health team and get the person into hospital if they're seriously suicidal.
And sometimes the really depressed patients can also be psychotic, but even if they're just depressed, they can, in my experience, become quite aggressive, particularly if you're suggesting that they might be suicidal or that we might need to transfer them off to a mental health unit. Do you have any ways of talking them down or dealing with that aggression?
If they're psychotic, it's probably no point even trying to talk them down. You're probably better off just going straight to medication to calm them down. And the most important factor there is that if you're with a person who's psychotic and aggressive, it's to protect yourself and look after yourself. Certainly no arguing with the patient. Don't even attempt to sort of change their views or whatever it is that they're angry about. But you don't necessarily have to agree with the person, but certainly do not challenge. If I'm caught with an aggressive patient who's psychotic, I will listen very quietly, and I will drop the tone of my voice, become more quiet, more placid, but not to an extent that the person feels like there's a kind of a grating in the relationship and I'm too quiet or I'm too slowed down. So just talk quietly and more slowly and listen. That's probably the most important thing.
Yeah, somebody told me once, don't look them in the face, but that doesn't sort of gel with me.
No, that actually in some patients will inflame them because they'll feel disrespected and that you're not really listening to them, so it's not a good idea. I would not necessarily do that, but I would certainly monitor. I'd never take my eyes off the patient.
And do you have a panic button or some other kind of mechanism for if things are starting to get out of hand or the patient is...
Yeah, I have. My room is actually set up in two ways. First of all, there's a low-slung coffee table, and it's just at knee height. And then there's my couch, and I have nothing between me and the doorway.
Yeah.
So if I want to get out that doorway, I can get out very quickly. And if I have to pin the patient against the couch, all I have to do is push my foot up against that table and pin them against that couch to get out. Then within my room, if I get cornered in my room, there is a panic button in my room that's connected directly to security people who will call the police. And my staff here all have panic buttons as well, duress buttons, that they can press and will call the police.
Dr. Daryl Managlio will be back again later in the programme for more discussion about situations that could pose an immediate threat to yourself or your patient. But for now, we'll return to Olga and Dr. Gary Wilkes.
Gary, apart from the really massive haemorrhages, like the shark attacks and the blown-off legs, how do you manage just a very large haemorrhage in a centre where, say, blood isn't available?
The basic principle in hemorrhage is press. All bleeding stops eventually, and if you can compress a bleeding point, compress it. And if that doesn't work, compress more. So if you're talking about limb injuries, for example, then straight ordinary compression is a wonderful thing to do. And if they're continuing to bleed through that, just press harder. You can actually get some tourniquets. I actually quite dislike tourniquets as an entity, like you see on the Rambo movies and stuff, because you never get up to arterial obstruction. You only get venous, and if you in fact have a bleed in the venous system, then you actually bleed all over the place. An arterial tourniquet will stop bleeding, but also cuts off all perfusion to the limb, and if it's going to be several hours, that limb will die. So I really dislike tourniquets for anything other than getting control of a bleeding point. The harder bits are the internal bleeding. If it's bleeding in the chest or bleeding in the abdomen, pretty much all the evidence says here is do nothing. In terms of if they have a large enough hole that they're bleeding down, if we give them anything to pick their blood pressure up to make us feel better because the number looks terrible, all you do is make them bleed out of that hole more. So the concept has always been a fluid challenge. You see someone who's hypotensive, who doesn't have obvious external bleeding, we give them a fluid challenge. And if the blood pressure comes up and stays up, we say, great, they've got controlled hemorrhage. They've obviously lost enough blood to require some treatment, so we move them on. But if the blood pressure comes up and goes down again, don't give any more, because that's an uncontrolled bleeding point, and anything you do from now on will actually make them worse. And it's really counterintuitive, because you want to give fluid, you want to give blood, you want to give all sorts of things, but you'll actually make them worse.
How large a fluid challenge would you normally give?
About 2 litres for the average adult.
And kids in the mil per kilo?
20 mils per kilo for children, and you can repeat that second time, and then you start thinking about blood. Kids are a bit different though, aren't they? Because we tend to manage trauma conservatively in children, and even things like macerated spleens and lacerated livers, they heal up without operating on them. So the operating on children is really quite a different matter.
You were talking about tourniquets earlier. What happens when the patient's bleeding through the pressure bandage, the appropriately applied pressure bandage? Do you actually apply more bandage around the outside, or do you take it off and redo it and repack it?
It really depends on what the underlying bit is. If there's a bit of a hole there, then you want a nice solid bandage on there. You don't want too firm a little ball pressing into it. You want an actual pad arrangement to spread the weight over the bleeding point. What I didn't mention earlier is if you do put a tourniquet on and get in there, don't tie off bits and pieces in there, because you may often tie off the thing you don't want to tie, and tying nerves and stuff is a very bad thing to do. So try not to have too tight a ball that you press in there. So just to fold it over bandage a couple of times, put another layer on it, and if it's bleeding through there, put another couple of layers of bandage over it so you've got a wider pressure area, and then wrap another bandage on top of that again. By and large, if your first layer is done properly, just keep going. Just press more. Eventually their blood pressure will drop down. That's why I said all bleeding stops eventually. And then you'll actually find it easier to get control of the bleeding point when that happens.
Unfortunately, when their jolly blood pressure drops down and they're shocked, vascular access becomes a real problem for the doctor.
Absolutely.
Any hot tips for getting vascular access in the shut down, sweaty grey patient?
Well, what we teach in EMST is venous cut down. I think that's a very useful skill, but the time to learn it is not when you've got the trauma patient in front of it. It's got to be a skill you've practiced ahead of time. I think the technology has now come to the point where the intraosseous devices, things like the EasyIO, I know you're not meant to mention brand names and stuff, but any of those battery-powered drills, intraosseous access, I think they're really good now.
Okay, now I've only come across the hand-operated ones for paediatric use.
Yes.
So you can now use one for an adult.
Yeah, so you're talking about the manual ones that you drill in for
screw it into
paediatrics?
The,
yeah, and they're pretty much like an ordinary
tibia,
cannula, aren't they? You've got a needle through a sheath and drill it in and take the needle out. The ones now, like the guns that are available, they're battery operated. They're just like an ordinary power drill. They're quite different in that they cut around the outside of the hole, so there's no cannula down the middle of them, and they literally take 2 seconds to use. You've got a good feel as you go into the bone. You can use them for adults and children. They've got different sizes, and I've been very impressed with the way they work. Either into the tibia, as you would have learnt for the kids, into the distal femur, or into the humerus. So just go straight in on the edge of the shoulder, drill in.
And same sterile or aseptic procedure as you would use.
Same as you would for any other. I've been very impressed. I think the technology has got to the point now where I've actually purchased one for my own emergency department, and I'm now convinced it's the way to go. Just a word of warning though, in that where if you do that on a conscious patient who you're getting access to put fluid in, well, it's no more painful than putting in an IV. In fact, you're using proximal sites, so the skin there is less sensitive than putting in back of hands and so on. So it's actually not that painful. On the manufacturers' videos for these, they have volunteers who do it, and they're smiling away as it gets drilled into their tibia. It's quite freakish. But when you do push the fluid in, a word of warning in conscious patients is expanding the bone marrow is really very painful.
Yeah.
So if you have a conscious patient, you need to put in 2 mils of local anaesthetic, non-adrenaline containing, for an average adult, and just give that 5 or 10 seconds before you infuse the fluid, or you'll get a patient screaming at you because it apparently is quite painful.
Yep. And under pressure, the same as you would for a paediatric intraosseous?
They run in remarkably easily, so you can just use it like ordinary venous access.
And resus fluids for shocky patients?
Oh, we've had the lot, haven't we? We've had colloid, crystalloid, Hartmann, saline, super salt solutions. In the latest edition of ATLS, they've made a specific statement about this, and that's one of the multi-choice questions you'll come across as well. All the trauma committees now recognise there's nothing to pick between them. Use whichever one you are comfortable with. There's clinical equipoise. There's no evidence to support one above the other for any subgroup. I know some people are particularly keen on concentrated salt solutions for head injuries, but there's no outcome data to support that. So whatever fluid you're used to using, use saline, use Hartmann's, just don't use dextrose. You want something that is proper electrolyte containing, but all of them, perfectly fine.
You talked about chest injuries and abdominal injuries and not overfilling them. Pelvic fractures. How do you stabilise those in a rural area where you haven't got all the gadgets?
Pelvic fractures are a major life threat that are relatively easy to treat. One of the good things about teaching on EMST is you get to meet all these other people who teach on it as well, and on one of them I had a trauma surgeon who specialises in pelvic fractures, so I got to pick his brain on it as well. He treats a couple of hundred a year. So I asked him about the various devices you have, the clamps and the pelvic binders and all proprietary things, or just tying a sheet. And he is very happy that tying a sheet is as good as stabilising a pelvis as any of the proprietary devices out there.
If you can get it tight enough.
But you've got to tie it on tight enough, yeah. What we don't do anymore is with trauma patients spring the pelvis. Because you lose between 1 and 2 units of blood every time you spring a pelvis if it widens open. And then what we typically do is then hopefully the patient's unconscious because they'll scream at you if they are conscious, is then we go and get someone else and say, hey, look at this, it springs open. That's a really terrible thing to do. They will exsanguinate. So with the open book pelvis, one that's opened up and is obviously broken when you touch the pelvis, it comes apart, you need to close it back in. So it is probably a 3-person operation to do this. One person holds the pelvis and pushes it in. The second person ties the sheet over it. Now remember, it's a pelvic sling, not an abdominal sling. So you tie it around to where jeans are now worn, which is way down over the hips, not up over the iliac crest. So fairly low down, not that far above where the actual neck of femur will sit. And one person pushes the pelvis in, the other one ties the sheet over and just loops it, and the third person ties a knot on it. And it's as simple as that. It's got to be low, and all you're really doing is stopping the pelvis from widening up further again. As a rough rule of thumb, if you see a pelvis and the symphysis is opened up with an open book sort of fracture, like the book goes like that, for every centimetre gap, the pelvic volume has increased by another litre. So if you've got a 5 centimetre gap there, you can lose your whole blood volume into a pelvis. You need to wind it back in to create that tamponade effect.
Now, our ambulance officers always used to bring patients with probable or possible pelvic fractures in a mast suit.
Yes.
And I've always just kind of blown up the pelvic part of that and left it blown. Is that okay to do?
The mast suits had a long history. For many years we thought it was fantastic because it picked up blood pressure, and then when we had a look it made no difference to outcome. I think it's on its way back. It's very useful for immobilising bilateral lower limb fractures, and it's very useful for immobilising pelvic fractures. If you're going to do that, you need to blow up the leg compartments as well. It doesn't auto-transfuse, it doesn't squeeze stuff back into circulation, but it does stabilise our pelvis and compress it in a ring sort of arrangement. But it's painful in a conscious person. So if you have the unconscious trauma patient, that's actually okay, they can't scream at you, but it does do wonders for helping in that hemorrhage.
I also still remember going to a car accident and seeing a leg sticking out of a shattered windscreen with a foot on sideways, blue and pulseless. So while the patient was happily unconscious, I reduced that and the limb well, the foot reperfused. If you've got something that looks kind of blue and pulseless, is just splinting it in a normal anatomical position going to perfuse it? And if not, how much time have you got?
I'm very glad you did that. You may well have saved that person's foot from doing it. If it's pale, pulseless and looking at you like it's dead, it's dying. We know you can survive for up to 6 hours or so without any perfusion to limbs. That's what we do with orthopaedic surgery on lower limbs. But really, the less time, the better. So if you can reduce it, if you have the confidence to reduce it, do so. And if you ever want to remember how to reduce dislocations, the way they go back in, it's a very simple process. You take the two bits, you distract them with as much force as you can, increase the deformity, and then pull it back to the anatomical position. That works for fractures, that works for dislocations, and despite how nasty they look, it's remarkably how easy some of them go back in. And once you've restored perfusion, splint it to maintain it there. And even in a conscious patient, if it's going to be many hours until you get transferred somewhere, please reduce the dislocation. If you have the capacity to give some pain relief ahead of time, go for it, whatever pain relief you are comfortable with using. But if you have to use brute force, just use brute force. It'll be over in a few seconds. You can apologise to them later when they have their limb survive.
Speaking of windscreens, very large foreign bodies like big pieces of glass and I suppose big knives and things, take them out, leave them in?
Depends where they are, really, and how good your knowledge of anatomy is. If there's an obvious penetrating injury, then the simple rule of thumb is don't take it out. If it's a large object and it goes in somewhere, especially things like necks, don't take it out. You don't know, you don't have any idea what's on the underside of it, what it's in. It could be in a vascular structure, where when you pull it out, you lose all that tamponade effect. So unless it's actually threatening their life, leave it in until such time as someone who can deal with the deeper consequences is around to do that.
I've seen all sorts of creative things to kind of pad up knives or bits of glass or bits of tree branch that have impaled people. Do you have any good practical jerry-rigged country doctor tips for trying to take the pressure off?
I like to be able to see the thing that's sticking out, because sometimes taking your coffee cup or whatever and putting it over the object and taping that in place, you sometimes lose sight of it, and when you hand over from one patient, from one care to the next, you can lose that information and someone not notice and just kind of give it a bit of a push incorrectly. Yeah. I actually don't mind seeing them when they're in there, but pad around it is probably the best thing to do so it can't get pushed down. So if you've got something sticking out the side of the chest, put lots of padding around it so you can still see the end of it. And I don't know, if it's something really big that's sitting out, tie a tag on it so you can see it. Make it obvious that it's in there. What I tend to do when I put dressings on in trauma and there's something underneath it is I actually write on it what it is. So if there's a laceration that's been dressed or a foreign body under it, put the bandage over it, just get your chemi pen and write down, big stick underneath or something so it's obvious.
Large sheet of glass, yeah.
Yeah, well, it sounds silly, but you'd be surprised how many people are thankful that you actually do that at the receiving end.
And country patients often present with lots of shotgun pellets in various bits of their soft tissue anatomy. How do you initially manage those in an emergency department?
That's again, it's a little bit tricky. It depends upon where the shotgun pellets are. If it appears to be okay, the ones you can get out easily, you get out. The deeper ones, you probably do more harm hunting for them than you do in actually getting them out. They are bits of foreign material, so if they do stay in, they become a tetanus risk, including having operations on that later on. Mm-hmm. So that you have to remember the tetanus cover when you go through that. What I tend to do with those, not that I've seen very many of them, is clean out the ones you can clean out without having to do too much deep exploration around the place, and then use the best tool we as doctors have, observation and follow-up. So watch them. Some of them tend to migrate, And if they've gone through vascular structures, you can get aneurysms and other malformations occur. So you've got to bring them back. You've got to bring them back and check them. It's always good to check everyone in 24, 48 hours anyway, and then another week or so down the track. But depending on how good your knowledge of anatomy is, and whether there's vascular structures underneath, forearms, for example, there's a reasonable risk you can hit a vessel and create problems. So bring them back and review them. If they do develop false aneurysms, then you'll be able to pick it by examining them. They'll have bruits, they'll have swellings, and often they have increasing pain. So clean out what you can. Firstly, do no harm, primum non nocere, and review. And anything that's new, trust it, believe it, follow it up.
Yeah, I suppose you see that also with the little bits of windscreen glass that pop out of people, 1 or 2 years later.
Yes, well, they can be pretty tricky as well. Again, if they're fairly deep and they're not causing any surface pain, leave them alone.
Leave them alone and wait for them to come out.
Go hunting down. And if they do develop a complication like they get infected, that actually makes it remarkably easier. You can localise them on ultrasound, and when you get down to an infected bit, it's got a little ball of pus around it and they just pop out all by themselves. If you try and get in there too quickly, it's too hard, you can't find them.
Our thanks to Dr. Gary Wilkes for once again being involved in our broadcast. For our final segment tonight, we return to our discussion with clinical psychologist Dr. Daryl Managlio, who has some advice about maintaining control when confronted by a manipulative patient or those who are pressing an agenda.
Daryl, in emergency departments, you quite often come across patients that are trying to con drugs or just simply con the doctor about an illness. How do you identify the charming con man or the charming psychopath that might come your way?
In emergency departments, my experience is that there are a particular type of patient that comes in. So, strangely enough, one of the first things I actually look at is for tattoos. And particularly the tattoo on the forearms. Now, I know tattoos are very popular these days, so it makes it a little bit more difficult. But to identify sort of people who are likely to be conning me, but that's the first thing I look for. The next thing I go by is my feelings. I pay very close attention to sort of how I'm feeling, and if I feel like I'm being kind of steered in a particular direction, I'm being kind of sold a pup, as it were, then yeah, no. Sort of tattoos, obviously, I look for things on the hand, like very poor tattoos, love, hate, sort of mother written somewhere, or sort of pictures of ex-girlfriends on arms or whatever.
I guess not so much in emergency departments, but all over. When GPs come across patients and they think they're not quite sure about this patient, but they feel that there's something wrong, how do you progress with their consultation and with treating them? Do you call their bluff or do you play along with it?
When you're dealing with somebody who you feel is manipulative or you believe is manipulative, I think it's very important to establish what is behind the manipulation. There are certainly some people who have to use ways and means to get what they need purely to survive. So, and I'm thinking of the sorts of patients that come in and they don't have food or they don't have money and they need forms, etc. to sign. And you know full well that perhaps they're not quite entitled to it for whatever reason, but you also know that there is family or people that they're supporting that they do need help with. So I certainly would be finding out what sort of all the charm is about behind that. If it's for more serious things like access to medications or drugs, then I certainly would not play along and to say, look, I just don't do that. I'm sorry, you'll have to go and find somebody else to talk to you about that if you can. So I just would not play along with it.
So sometimes you do just get that feeling that somebody's trying to push their own agenda, but sometimes it's not for drugs or not for days off. It's just that the patient thinks that they're ill and you know that they've got a whole stack of other perhaps psychological issues or a whole stack of other personality issues. How do you kind of steer the patient round to an understanding that that's what the problem actually is?
This is very complicated because often I would imagine that there is a fair portion of people who actually come to GP practices who come because the only contact they have is the nice, warm, fuzzy GP who is prepared to sit and listen to their problems. And if you try and steer them away from that, the person usually does become upset or feels abandoned, and then you do have sort of a problem on your hands. I certainly would say to the person, or encourage the GP to say to the person, basically, look, I've got this UBU guy or person that you should go to, and he's really good, he's nice, and he'll listen to you. And so it's kind of, you're doing a bit of manipulation yourself, but the idea is that I'm working alongside this person. It's okay for you to go and see this person. If they think, well, I haven't got a psychological problem, then usually when patients come to see me, I'll explain the connection between stress, physiology and psychology, and sort of remind them or suggest to them in the last few years there's been this new emergence of a new field called psychoneuroimmunology. And it's a mixture of psychologists, immunologists and neurologists have got together and looking at stress and the effects of stress on the body, and how when people get stressed, their body treats the stress just like any invading pathogen, and the person gets unwell.
Yep.
They have these funny symptoms. So that kind of helps people kind of have a bit of a model that they can say, yeah, I've got this kind of connection between my physiology and psychology, and I'm using psychology to help myself. Mm-hmm. But I've found that most of the time, if there's a connection with the GP, they will gravitate back towards the GP, and there's not much I can do about that.
As a female GP, you do sometimes feel very vulnerable because some of your patients will, try and make inappropriate advances or inappropriate comments, or just simply become terribly dependent and try and make lots of appointments for trumped-up psychosomatic complaints. Do you have any useful hot tips for dealing with that kind of patient?
If I get that sort of patient, I recognise the dependency and the insecurity that's underneath, and usually what I do is I will schedule a regular time for that person to come, and that's their time. And I will do that with whatever frequency I need to basically keep control over the situation. So if the person, I believe, if I see the person twice a week, and that stops 100 telephone calls, I can say that to me is a good outcome. If I say to the person, I'll ring you at 12 o'clock on Thursday lunchtime, and I'll speak to you for 10 minutes, that to me saves an awful lot of time, and I don't have lots of telephone calls with all sorts of funny complaints or tears or whatever.
The other half of that question was the patient who is making an inappropriate advance. Do you have any sentences or things that you say or do to try and re-establish professional distance, or do you just simply have to terminate the relationship?
I don't terminate the relationship because the people are in a therapy relationship with me, so I see that as just part of therapy at the end of the day. Mm-hmm. I'll acknowledge the fact that I'm important to them. If I was in a GP situation, I would remind them just very gently that it's okay to appreciate me as their GP or appreciate me as their therapist, but that they really don't know me at the end of the day. It's always good if you've got a partner around the place that you can kind of be seen with your partner, as it were. So in my office I've got pictures of my wife and I've got pictures of my family, and that sets a boundary as well. So they kind of overlook the therapy, as it were.
Well, that's all we have time for tonight. I hope you enjoyed the broadcast and that you found it useful both to you and your practice. Now, don't forget, if you'd like to review this program or any previous program, you can watch them online or download them as a video or audio podcast via the Rural Health West website at www.ruralhealthwest.com.au. We'll be back again on the 7th of July with a program on palliative care. Our thanks again to Dr. Olga Ward, Dr. Gary Wilkes and Dr. Daryl Managlio for their time and expertise. And thanks to you for taking the time to join us. Good night.